Hey there, and welcome to this explainer. Today we're diving deep into the complex and honestly fascinating world of neuromuscular pharmacology. Consider this your ultimate exam-focused guide and clinical toolkit. We'll unpack the critical safety warnings attached to these heavy-hitting medications and figure out exactly how to safely apply all this knowledge in a real-world clinical setting. Let's just jump right in.
Okay, here is our roadmap for today. We're going to start with disorders in EPS, break down the benzodiazepines, compare our muscle relaxants, look at GABA analogs and neuropathy, explore MS immunomodulators, and finally wrap it all up with a clinical application summary.
All right, Section 1. Disorders and extrapyramidal symptoms.
Before treating anything, we really have to understand the baseline. Take dystonia, for example. It's a key clinical manifestation of conditions like cerebral palsy, which we know impairs posture and motor development. But here's the catch. Dystonia is also an acute extrapyramidal symptom, or EPS, that demands your immediate attention. We're talking severe, incredibly painful muscle spasms of the neck and body. Sometimes it's so intense it forces patients into a fully arched posture.
Now, we can basically split these extrapyramidal symptoms by when they show up. Acute EPS hits suddenly. That's your painful dystonia or pseudo-Parkinsonism, which brings on those slowed movements and tremors that look exactly like Parkinson disease. Or even akathisia, where a patient literally just cannot sit still. On the flip side, tardive symptoms are delayed. They sneak up long after the medication was started, showing up as involuntary facial tics, lip smacking, or excessive blinking.
Moving on to Section 2, the benzodiazepine breakdown.
So what happens when a benzodiazepine enters the system? It acts as a direct-acting receptor agonist. It arrives at the receptor and totally boosts the activity of GABA, which is our brain's main inhibitory neurotransmitter. This boost causes a rush of chloride ions into the neurons, effectively depressing the central nervous system and directly calming down that muscle stiffness and those unwanted movements.
To absolutely lock this into your memory for the exam, you've got to use the low and slow motif. Since benzos depress the central nervous system, they drop pretty much everything. They decrease respiratory rate, which is a huge safety priority. They lower blood pressure. They slow down GI motility, meaning constipation. And they tank energy levels, leading to profound sedation. The rule of thumb, benzos at bedtime. Oh, and definitely remind your patients to change position slowly so they don't get dizzy. But here is the absolutely crucial point, highlighted by a stark black box warning from the FDA. You cannot take this lightly. These drugs carry profound risks of physical dependence, misuse, and life-threatening withdrawal if they're stopped abruptly. We are talking delirium, psychosis, and active seizures. They absolutely require strict, gradual tapering. And if you mix them with opioids or alcohol, it is a guaranteed recipe for fatal respiratory depression.
Let's say the worst happens, and you have a patient facing severe respiratory depression, hypotension, or bradycardia from a benzo overdose. Your clinical rescue tool is flumazenil. It's a competitive antagonist given via IV. But a major word of caution here. While it reverses the toxicity, pushing it can rapidly trigger acute withdrawal and seizures. You have got to watch their respiratory and cardiac status like a hawk after administering it.
All right, Section 3. Muscle relaxants compared.
When dealing with severe spasticity from cerebral palsy or multiple sclerosis, an intrathecal Baclofen pump is a real game changer. It delivers precise microdoses of medication right into the fluid surrounding the spinal cord. This localized action is brilliant because it avoids all those widespread side effects. But if that pump fails abruptly or the battery dies, it can cause lethal withdrawal. Think soaring fevers, extreme rigidity, and rhabdomyolysis. It's so important to understand the stark contrast between our skeletal muscle relaxants. Baclofen is centrally acting. It works right in the brain and spinal cord as a GABA-B receptor agonist. Dantrolene, though, it is peripherally acting. It completely bypasses the central nervous system, goes straight to the skeletal muscle, and stops the release of calcium right at the source. We need to ramp up the urgency again because dantrolene carries a terrifying black box warning for hepatotoxicity. This isn't just a minor liver hiccup. We're talking potentially fatal liver damage. So as a clinician, ensuring your patient has baseline liver function tests and continuous enzyme monitoring is a non-negotiable priority. You've got to watch closely for jaundice, abdominal pain, and extreme fatigue.
Section 4. GABA Analogs and Neuropathy.
Now, unlike our benzodiazepines, which bind directly to the GABA-A receptor to let chloride in, non-benzodiazepine GABA analogs, like gabapentin, just structurally mimic GABA. They don't actually bind directly to GABA receptors at all. Instead, they act as membrane stabilizers by modulating calcium channels on the neurons. This indirectly dials down the release of excitatory neurotransmitters.
You have to be super vigilant with pregabalin. The FDA put out a boxed warning for serious breathing difficulties, especially for folks with respiratory risks like COPD, or if it's misused with opioids. And just like benzos, suddenly stopping pregabalin triggers an incredibly intense withdrawal syndrome. Patients will face severe anxiety, heavy sweating, and insomnia. You've got to taper them.
Section 5. MS Immunomodulators and Injection.
Let's talk about multiple sclerosis. Direct-acting immunomodulators, specifically interferon beta-1a and 1b, are just incredible for reducing MS exacerbations and slowing down physical progression. They modulate the immune response and even have antiviral effects. But here is the critical nursing assessment. You must constantly screen these patients for severe depression and suicidal ideation, right alongside monitoring their blood counts and liver function. Since these MS meds are usually self-administered via subcutaneous injection at home, you are stepping into the role of educator. Keep your talking points simple and structured. Number 1, strict asepsis. Wash hands, clean the surface. Number 2, constantly rotate those injection sites to prevent tissue damage. And number 3, always use a puncture-proof container for the needles. And a huge part of that patient education is emphatically telling them never to toss used needles into their regular household trash or recycling. No way. They absolutely have to use proper hazardous waste drop boxes, supervised collection sites, or mail-back programs for their biohazard sharps containers. Safety doesn't stop at the patient's body, it extends right out into the community.
Finally, Section 6. Clinical Application Summary.
Okay, think of this as your quick reference mental checklist. We just unpacked the massive respiratory risks of benzodiazepines, the lethal pump withdrawal of Baclofen, the severe hepatotoxicity of Dantrolene, the breathing dangers tied to GABA analogs, and those critical suicidality risks with MS immunomodulators. To really thrive in a clinical setting, you've got to rank your assessments by urgency. Follow your ABCs. Airway and breathing absolutely come first, especially for patients on benzos or pregabalin. After that, check critical organ function, like the liver for Dantrolene. Then verify mechanical status, like that Baclofen pump. And finally, assess mood and suicidality for anyone on interferons. Let's leave off with one final diagnostic scenario. Imagine a cerebral palsy patient on intrathecal Baclofen suddenly presents with a high fever, altered mental status, and extreme muscle rigidity. What is the immediate suspicion? You have got to suspect a depleted battery or a pump malfunction. Catching that mechanical failure before it spirals into rhabdomyolysis will literally save their life. It just proves how powerful and potentially dangerous these clinical tools can be. Thanks so much for hanging out with me for this explainer, and I'll catch you next time.